Thank you, everybody, for joining us tonight. I'm Jim Erickson with Monteris Medical. I'm the CFO, and I lead our marketing and strategy efforts here as well. Thanks for taking time out of your busy schedules tonight to join our webinar on optimizing the management of recurrent metastatic brain tumors. Tonight, we've got a great multidisciplinary panel from the Wake Forest School of Medicine. Joining us tonight is Dr. Michael Chan, Dr. Roy Strowd, and Dr. Adrian Laxton. The Wake Forest team's been a great partner of ours at Monteris and been a long leader in the area of laser ablation in the brain. And tonight they've agreed to share some of their multidisciplinary practices around how their experiences have shaped their approach for LITT in brain metastases. So without further ado, I'm going to turn this over to Bill for a couple of technical overview items today, and then we're going to quickly get it to the panel to hopefully share their experiences and enjoy the talk.
Great. Thank you very much. I very much appreciate being here. It's always an honor and a delight to be able to speak in front of you. And I'm thankful that my colleagues, Dr. Strowd and Dr. Laxton, are here. We're going to be tag teaming this lecture, which is the optimizing the management of recurrent metastatic brain tumors, a multidisciplinary approach. I'm a radiation oncologist, and I'll be starting out this. Our disclosure slides. So the objectives of the lecture today are to understand current treatment recommendations for recurrent brain metastases, to acknowledge the importance of deciphering tumor progression from radiation necrosis, dissect the pros and cons of current available treatments for radiation necrosis, and discuss the role of LITT in this management paradigm. So an update, 2022, where are we with regards to brain metastases? So over the decades, there's been a stage migration. If you look at the early studies of brain metastases from the 60s and 70s, you had patients with large symptomatic brain metastases that were discovered because of the symptoms. And now patients present due to brain metastases detected on routine imaging, staging MRIs, and so improved imaging leads to increased number of brain metastases, and the brain metastasis population is now approximately 200,000 in the US every year, with lung cancer being the dominant histology representing 50% of these patients. And one thing that we have also found is that patients who present with symptomatic brain metastases are more likely to die of brain metastases and are actually more likely to have a worse survival. So that brings us to the incentive of catching new lesions before they're symptomatic, and to also follow our brain metastasis patients before they become symptomatic with recurrences, because the ability to catch brain metastasis recurrence, whether it be new brain metastases or locally recurrent ones, can lead to differences in outcome. So when a patient is diagnosed with a new brain metastasis, some of the options are below. Patients can have surgical resection followed by radiosurgery to the cavity. These are often for larger brain metastases. LITT, laser interstitial thermal therapy, is an option for patients with inaccessible lesions not amenable to surgery. Patients with limited number of brain metastases are eligible for stereotactic radiosurgery. What number represents limited is a moving target, and some of the current studies are allowing as many as 15 lesions to be treated with SRS alone. Whole brain radiation or hippocampal avoidant whole brain can be used for numerous brain metastases or patients with leptomeningeal spread. And systemic therapies are carving themselves a role for patients with brain metastases, including patients with small cell lung cancer can be treated with chemotherapy alone up front. Melanoma patients can receive dual immunotherapy. Patients with ALK or EGFR mutated cancers with small asymptomatic brain metastases can be treated with targeted agents. And there are studies essentially assessing now targeted agents for HER2 positive breast cancer brain metastases. So what's happening is that the number of patients that are eligible and are being treated with stereotactic radiosurgery is going up, potentially even exponentially. And so what we have found at Wake Forest, as well as validated amongst our colleagues at some of the major academic medical centers in the US and Canada, is that when patients have a single brain metastasis, they tend to do fairly well. But if they have 2 to 4, maybe they don't do quite as well, but they still have a decent prognosis compared to historical controls. And even treating greater 5 and greater does not worsen your outcomes by that much. And so patients, it seems that really it's the cumulative volume that's treated as opposed to the number of brain metastases that makes the difference in terms of a patient's prognosis. So thus, there has been an explosion in the number of patients who are being treated with upfront stereotactic radiosurgery. We are also being more aggressive with larger lesions. Here is a paper published by our group a few years ago, looking at treatment with larger lesions, either with stage radiosurgery. Patients can be treated with hypofractionated radiation. So we're treating larger lesions than had been treated before as well. So what's the consequence of being more aggressive with radiosurgery up front is that we have more need for salvage of new brain metastases, more local failures, and more radiation necrosis, right? And so by virtue of us being more aggressive with radiosurgery, we are having more events afterwards that need to be dealt with. So what are the options for recurrent brain metastases? Well, patients can have surgical resection, and if they do, they often are better managed with some sort of adjuvant therapy, whether it be repeat SRS to a cavity or placement of BCNU wafers. That the data seems to suggest that treatment to a cavity or adjuvant treatment after surgical resection may lead to better local control outcomes. Patients may have, and there's emerging data for repeating SRS to the same lesion that has been treated before. Disadvantage of that is that there's no pathologic confirmation. LITT alone or LITT plus SRS have been reported as salvage options, and that's major topic of our discussion tonight. So we'll get to the actual slides on that. And then again, as we had mentioned before, systemic therapies are carving their niche into when do we or how do we treat these patients with salvage. So a public service announcement that LITT has now made the NCCN guidelines. And so if you look at the NCCN guidelines as of version 2, 2021, MR-guided laser interstitial thermal therapy is approved by the NCCN and recommended as a Category 2B recommendation for recurrent brain metastases and for radiation necrosis. So one of the issues is, and we were one of the first series to publish doing radiosurgery to the same lesion that has previously been treated for a local recurrence. So again, as we mentioned before, one of the major disadvantages is that you don't have paths. So sometimes you could be treating radiation necrosis with another round of radiosurgery, and what that leads to is it can be worsened radiation necrosis. And also, there's a small chance, but real, that patient can get a fulminant radiation necrosis, which can be life-threatening or require surgery. But as you see from this slide, there is a dose-volume relationship, but anything less than 1 cc, the risk is relatively smaller, at least acceptable when treating a lesion a second time. But once you get beyond 1 cc, the risk of radiation necrosis is approaching 50%. So the investigators at MD Anderson actually came out with a publication in neurosurgery not that long ago. It was actually quite helpful in defining the use of LITT and which patients would benefit and which patients actually may be at high risk of local recurrence after laser. And so what they found was that if patients do not have a complete ablation, their local recurrence rate is quite high. Again, larger lesions, so here defined as anything greater than 6 cc's, had a much higher risk of local recurrence. Lesions that were dural-based, there appears to be some issue with dural-based lesions and the ability to get, sort of conformal heating. And then obviously patients who have had radiation necrosis have a better rate of having being progression free as compared to patients where they actually have true tumor recurrence. And that's been seen in multiple previous series. So when patients have radiation necrosis in the MD Anderson series, they did not reach a median time to recurrence because the treatment was so successful rated for radiation necrosis. When they had tumor local recurrence, the median time to another recurrence was approximately 14 months. So that's where using SRS as adjuvant therapy, so SRS to the LITT cavity after a local recurrence of a previously treated brain metastasis that has previously been treated with radiosurgery. So this is now published by the Duke Group recently in the Red Journal, which is the big radiation oncology journal. And essentially, it is in the similar principle as doing radiosurgery to a resection cavity after craniotomy. The radiosurgery seems to improve the local control. And as you can see, compared to doing SRS alone for these, or for recurrent brain metastases, or laser alone for recurrent brain metastases, LITT plus SRS leads to a much better degree of much better progression-free survival, right? And with a median progression-free survival in their series of 23 months, which is quite good. So this is something that we have been adopting at Wake as well. Essentially what we target is the gliosis, the enhancing gliosis around the laser cavity. So what we use for indications at Wake, at high volume institution for LITT, in terms of when do we offer SRS post-LITT. Anybody who had an incomplete ablation, any lesion with a target volume greater than 6 cc's and dural involvement, right? If there are larger lesions that both the pre-SRS and the post-LITT lesions are larger, so in our hands generally greater than 2 cm, we consider doing hypofractionation, right? So breaking up the SRS into at Wake 4 fractions, right? And we generally try to complete the adjuvant treatment within 4 weeks of the laser. And wanted to bring up the remaster study. Dr. Laxton is one of the investigators on this, where patients, this is now a study on clinicaltrials.gov. It has a national identifier. It's basically patients where they have recurrent tumor. They are either treated with laser or laser followed by hypofractionated radiation. So about radiation necrosis, because one of the major advantages of laser treatment is that not only can it treat a tumor recurrence, but also in the same procedure you get pathology, and it is also quite effective for radiation necrosis. And the reason why comes from the mechanism, right? So radiation necrosis is a permanent radiation injury, can be symptomatic, can be morbid. It's a delayed complication, occurs generally 3 to 18 months after SRS, and it can definitely affect patients' quality of life. But the mechanism is driven by a molecular cascade that's mediated by VEGF, right? So it's a cascade of events that occurs molecularly that's mediated by VEGF, and that's one of the reasons Avastin is such a good treatment for radiation necrosis. But again, because this cascade is occurring in a local region, when you surgically resect the area where the cascade is occurring, it tends to treat and blunt the cascade, and patients tend to get better. And similarly, if you do laser ablation to the region where this cascade is ongoing, you ablate that cascade that is occurring in that local region in the tissue, and patients tend to get better. So this is just a diagram to give you an idea. So there's the dichotomy between pseudoprogression and radiation necrosis. Pseudoprogression tends to be a transient endothelial injury, can happen and can be treated with surgery, can be treated with laser treatment, often can resolve on its own. Tends to be worse in patients who have immunotherapy, right? The radiation necrosis is a distinct disease process where it is mitigated by this VEGF pathway and tends to happen anywhere from 3 to 18 months after. The pseudoprogression tends to occur before that. So again, pseudoprogression is often glial injury mediated, whereas radiation necrosis happens after that, is no longer subacute, but tends to happen several months later. It tends to be vascularly mediated, but also immune mediated and glial cell mediated. So one of the big concerns with radiation treatment effect, which encompasses both pseudoprogression and radiation necrosis, is it's very difficult to tell on conventional imaging and distinguish on conventional imaging between the radiation treatment effect and tumor recurrence. And there have been multiple studies that have found, relatively poor sensitivity and specificity using conventional MRI, trying to compare, edema volume and enhancing tumor volume to try to find distinguish between these two phenomena. And really, biopsy is a gold standard. As you can see, this is the timeline of radiation necrosis. It tends to occur mainly from 3 to 18 months after SRS, but can happen even after that, but really plateaus after about 2.5 years. So there are relatively few events after that. The risk of radiation necrosis is affected by the volume treated, the radiation dose. So how big the lesion is, how high of a dose is treated, whether patients get systemic therapy simultaneously. Particularly immunotherapy is a big mitigating factor, has increased the risk of radiation necrosis. If patients have had previous whole brain radiation, that also increases the risk. This is actually from a paper that we published from Wake. If you look at the radiation dose volume curves, patients with immunotherapy have a much steeper event curve when it comes to radiation necrosis. So they have, higher doses or higher volumes leads to a much greater degree of, it's a completely distinct dose volume relationship compared to patients who are not on immunotherapy. This is just a summary of some of the data available for looking at progression versus necrosis. They're using new biologic imaging like PET, spectroscopy, diffusion, but again, nothing is really perfect for distinguishing progression from necrosis, and really biopsy is the gold standard. So what do we do at Wake? So if patients generally come in and they have increased enhancement, if the lesion's less than 1 centimeter, I often will just repeat the imaging in 6 to 8 weeks. The biology will often declare itself, and sometimes you'll have self-resolution of the lesion. But once you're greater than 1 centimeter, we consider pathologic confirmation, stereotactic biopsy, laser, craniotomy. And so if patients have symptomatic edema or mass effect, oftentimes we can consider steroids. But if they're on immunotherapy, you have to be careful because the steroids can blunt the effect of the immunotherapy. And so if patients have symptomatic edema or mass effect and they're on immunotherapy, really would consider early resection or early laser as early intervention. All right, so I'd like to pass on to my colleague, Dr. Strowd. It also, right now is not a bad time to see if there are any questions that people might have. The sort of natural break in the talk.
Yeah, thanks, Mike. Yeah, we'll give it a brief pause just to see if there are any questions that come up. And again, you can type your questions into the Q&A And we're happy to address those as we go through the talk, or can also cover them at the end. And unless we see any, we will keep moving along, but please do, and we welcome questions as we go through. So I'm Roy Strowd, neuro-oncologist at Wake, and we're going to transition a little bit. What's the role of the neuro-oncologist? What are our treatments for radiation necrosis? Dr. Chan's really set us up nicely for the controversies around recurrent brain metastasis and radiation necrosis. And now we'll dive into some of the treatment options for radiation necrosis, both medical and surgical, and then hand off to Dr. Laxton to finish things off. So I want to back us up just a little bit before we dive into the treatments for radiation necrosis and talk a little bit again about the importance of biopsy and underscore a few of the things that you've just heard Dr. Chan say. The first is symptoms of radiation necrosis and progressive tumor overlap. And then I'm going to move us down to the end of the slide, MRI findings that you just heard of radiation necrosis and progressive tumor overlap. And we get into these controversies in tumor board repeatedly: progressive enhancement after SRS. What is it? Is it radiation necrosis? Is it progressive tumor? And biopsy can be critically important. I think that really is where LITT offers an advantage over some of our other conventional approaches. Steroids may help the imaging look better, but may blunt our ability to understand what the underlying pathology is. Bev does the same and really prevents our ability to undergo surgery for that patient for a period of time. And so LITT and biopsy can be an important first step in many of these patients. Misdiagnosis of radiation necrosis as tumor can be harmful, can impact the patient, leading to progressive or possible repeat SRS, which may worsen radiation necrosis. And again, misdiagnosis of tumor as radiation necrosis also will delay appropriate therapy. So important to consider the role of biopsy in initially evaluating these patients. Once the diagnosis is made, what are our treatment options for radiation necrosis? Well, first, we step back and need to evaluate whether this patient is symptomatic or asymptomatic. As you just heard from Dr. Chan, our practice pattern is for patients who are asymptomatic to evaluate with serial scans, with or without steroids in those patients with progressive imaging changes. The earlier we can intervene in that cascade that you saw from Dr. Chan's slide previously, the better. And so we do consider early intervention, but in asymptomatic patients, serial scans is a consideration. In patients who are symptomatic, typically we would begin with steroids, but increasingly we have additional tools in the toolbox for these patients with radiation necrosis. We'll talk a little bit about the data and practice pattern for bevacizumab, surgery, and LITT. And then a number of other therapies can be used. We talked about a patient a few weeks ago who failed steroids and bev and surgery. And then we get to things like vitamin E and pentoxifillin. There's very limited data. I wonder a little bit about whether we're treating ourselves as opposed to the patient, but that is a consideration. Verapamil, there's very little data on, though I have tried this on a number of patients who have been refractory. And then I have one slide on hyperbaric oxygen therapy. There's very limited data on the efficacy, but I do think this is safe in our patients, and it's something that we have considered in a number of particularly refractory patients. So let's talk through each of these treatment options for radiation necrosis. And we'll start with steroids, because that's often where we start with these patients. Steroids reduce inflammation and edema. If you think back to that slide of the VEGF cascade or that hypoxia cascade of radiation necrosis, this is really intervening down at the far end of that cascade. I think step 8 was inflammation and edema. So it's providing symptomatic relief for patients, doesn't reverse the underlying pathophysiology, the driver of necrosis. We see a number of side effects with steroids: diabetes, weight gain, myopathy, psychosis, poor wound healing, immunosuppression, particularly of those patients who are on immune checkpoint therapy. So you're likely familiar with steroids, and it's an important tool, but increasingly we see use of other agents in addition to or as an adjunct in these patients. There is some data on steroids and comparing steroids with bevacizumab. This is a study from the MD Anderson group in Journal of Radiation Oncology, looking at imaging changes after steroids and imaging changes after bevacizumab. And you can see 20% of patients with reduction in flare after steroids. So again, we see improvement in imaging in these patients. But in comparison, 51% of patients with bevacizumab, both with flare and 25% with reduction in enhancement. And so increasingly, we do see the use of bevacizumab for managing radiation necrosis in these patients. Many of you may be familiar, and I assume are familiar with Bev, but for those who are not, This is a recombinant humanized monoclonal antibody that inhibits the VEGF ligand. When we think about treatment of primary gliomas, it's palliative. There's no impact on survival, and there are a number of both common and rare but serious side effects that we must consider with this therapy. Headache, fatigue are those common things that we hear from patients, particularly in those on chronic or more prolonged therapy. And the rare but serious side effects, gastrointestinal perforation, thrombosis or venous thromboembolism, impaired wound healing, and renal toxicity, both hypertension and proteinuria, more common as we continue therapy and in those patients with underlying diabetes. And cost is not an insignificant issue for patients and payers. How about Bev? How does it work, and where does it play in the treatment of these patients? As we've discussed, it is an anti-VEGF agent, which is critical in the underlying pathophysiology of radiation necrosis. A number of small case series has shown improvement in post-treatment imaging, and so we do see improvement in imaging, the ability to withdraw steroids in up to 50% of patients treated with this agent. Unfortunately, recurrences we do see after bevacizumab is discontinued. Typically, this is a therapy that we would consider for 4 or 6 cycles of treatment and then withdraw the agent. We see durable responses in a majority of patients, but can see recurrence after discontinuation. So how about some data? I want to review 3 studies looking at bevacizumab and Bev versus LITT and talk about how we utilize these at Wake. First, let's look at Bev. This is a review published in 2021 of 12 studies, 89 patients. And really the data I want to highlight from this is the incidence of recurrence after Bev use in those patients who are treated for radiation necrosis. Up to 77% of patients can recur after Bev. So we use this agent, it works, it improves imaging, patients are able to come off steroids. There is no level 1 evidence for Bev. We have one randomized trial from the MD Anderson group looking at Bev for patients with radiation necrosis from gliomas and metastasis. The Alliance study, the BEST study, began. It was an important study to evaluate the role of Bev in radiation necrosis, but accrued poorly due to really active clinical use of bevacizumab for patients with radiation necrosis. And so while this has a critical role for treating patients with radiation necrosis, there are a number of issues that we've talked about in terms of side effects, cost, and risk of recurrence after this agent. So what about surgery? Where does surgery fit in our treatment for radiation necrosis? You're going to hear a little bit more about this from Dr. Laxton. This is the gold standard of treatment, particularly for patients with symptomatic radiation necrosis, those large lesions with significant edema in patients with symptoms, in patients who have associated increased intracranial pressure or hemorrhage. This can be a particularly attractive option. Reduces steroid requirement nearly immediately or quite quickly, which we don't see with Bev and to a lesser degree as well with LITT. There are survival benefits in patients who have failed medical therapy, and we can often combine this in patients who will ultimately go to surgery and are found to have progressive disease. This is a nice study, again, from the MD Anderson group, looking at the benefit of LITT versus craniotomy, really showing that in patients with radiation necrosis or progressive tumor, LITT and craniotomy really perform similarly in terms of progression-free survival, which you see on the top, and overall survival on the bottom. And so we really can utilize both of these, not only in terms of diagnostic capabilities, is this progressive tumor versus radiation necrosis, but also therapeutically. And then LITT, which is really the focus of our conversation tonight. LITT, as this group knows, is a minimally invasive surgical option with very short recovery times. Patients come into the operating room, a stereotactic biopsy is performed, allowing us to understand what is going on physiologically. Is this radiation necrosis or progressive tumor? Typical length of stay is 1 night, which is optimal for these patients who need to get back to subsequent systemic therapy. We can see decrease in steroid independence, although I think in comparison to bevacizumab and surgery, we see patients who can remain on steroids for a slightly longer period of time, which is a consideration with this therapy. And LITT, as you've seen, is included in the NCCN guidelines for treating patients with progressive tumor and for radiation necrosis, which I think is important to take away from this talk. And what happens when patients fail all of those therapies? Steroids, bevacizumab, surgery, and/or LITT therapy. What are some of the other options that we may consider? This gets into a number of controversial discussions in tumor board of what to do with these patients, and happy to entertain some of those questions and talk as a panel about what we do. I think hyperbaric oxygen is something that we have discussed in our tumor board. There's no prospective studies evaluating the efficacy, but a number of small case series showing that it can improve tissue oxygenation in the brain. The doses we look at are those that are used to treat patients with a wound and other more cutaneous areas of necrosis. It can provide reduction in steroid dose. And I think importantly, there's a number of studies looking at its safety in this population, really not showing an increased incidence in tumor recurrence, which was an initial concern as a result of potentially driving tumors through oxygenation. So I think this is a safe therapy, although unclear efficacy in this patient population. So to finish us off, let's talk about how we can put these therapies together and really select the optimal treatment for our patients with radiation necrosis. And I want to review two studies. The first is from the MD Anderson group. This study initially a poster in Neuro-Oncology Advances and subsequently published in the Journal of Neuro-Oncology, a systematic review and meta-analysis of Bev versus LITT for patients with radiation necrosis. And I'll summarize the key data here. This is a literature review of 18 studies, 143 patients undergoing Bev compared to 148 who underwent LITT. All of these patients and studies looking at patients treated retrospectively. LITT and Bev were found to be equally effective for treatment of symptomatic radiation necrosis. We see steroid withdrawal with both of these treatments and immediate lesional control with both therapies. At 6 months, the rate of regression, as you can see here, is significantly higher in the Bev group. So patients treated with bevacizumab are more likely to come off steroids and have regression of tumor on or radiation necrosis on imaging at 6 months. In the LITT group, we're more likely to see stable disease at 6 months and longer survival at 18 months in the LITT group. So this is, I think, important data for us to understand the utilization of both of these therapies. I think we tend to think of Bev in patients with multiple lesions, those patients who have that wispy contrast enhancement following radiation therapy, and as well as patients requiring significant steroids, needing early withdrawal. The second study is a study from the group at Yale. This was published in the Journal of Neuro-Oncology just recently in 2020. This is a single institution retrospective review, 25 patients retrospectively who had previously undergone LITT versus 13 patients treated with bevacizumab. And we see very similar data in this study. The LITT cohort showed longer overall survival. You can see here 25 months compared to 15 months in those treated with bevacizumab, a trend also towards longer progression-free survival, and again, earlier withdrawal of steroids in patients undergoing bevacizumab. So I think intriguing data, important data. There are some limitations. Both of these papers are evaluating data retrospectively. There's a number of selection biases when we're looking at these studies. We do need better prospective data. I think clinically we tend to, at Wake, utilize bevacizumab for patients who have multiple lesions, patients who where there is imaging certainty or near certainty in the underlying diagnosis, and LITT for patients with singular lesions, and certainly for patients where there is diagnostic uncertainty. What is this? Is this progressive tumor or radiation necrosis? And we can achieve both that diagnostic and therapeutic intervention in the same procedure. So with that, I'm going to turn it over to Dr. Laxton. I'm happy to take any questions about management of radiation necrosis now, or we can also save those for the end.
Here's the question. How strong of a contraindication is DVT or anticoagulation use for Avastin? There are studies that have investigated this in glioma patients with 10% intracranial hemorrhage rate, but I imagine the factors in systemic factors may change that equation. So wondering the team's reaction to that question.
Yeah, it's a good question. I think it brings up two questions. One is, what's the risk of recurrent VTE with utilization of bevacizumab, and then the second is in patients who have VTE who are on anticoagulation, or what's your hemorrhage risk and concerns there. I tend to quote patients about a 4% risk of hemorrhage, 2 to 4% risk of hemorrhage, with a primary or secondary brain tumor alone. That number going up to probably about 6 to 8% with the addition of anticoagulation. And then most studies report a hemorrhage risk with the addition of Bev on top of anticoagulation around 20 to 25%. So I think the risk of intracranial hemorrhage is of significant concern in patients already on anticoagulation. I think 4 maybe 10 mg per kg as a dose for 4 to 6 doses of Avastin, and we can see very early imaging responses. But I think that is a consideration in patients who are at high risk of VTE or currently on anticoagulation. Surgery is or LITT. It offers them temporary time off of anticoagulation without that sustained risk of intracranial hemorrhage. VTE alone, a absolute contraindication to Bev, but it's a consideration for these patients and in patients who are very high risk of VTE. There is a risk of increased VTE in patients who are on Bev. Mike, Adrian, I don't know if you have anything to add to that.
What I'd say is, as we've kind of alluded to, there's kind of an order of things, and depending on what sort of radiographic progression we see, our first, course of action may be to repeat imaging in 6 to 8 weeks, right? And then if we're seeing more symptomatic radiographic progression with edema, we might move to steroids. And then it's a question of what do we do after that? And that may lead us to surgery, LITT, and bevacizumab comes a little later in that algorithm. And some of the issues that we're raising highlight, in addition to many other things that you mentioned, Dr. Strowd, why we would order it in that way.
One other question that maybe is a clarification. So the question was the randomized alliance trial that you mentioned. The question is comparing Bev versus LITT did not accrue well, although I don't believe it was a Bev versus LITT trial that you were referencing. It said, what was the reason? Maybe if you've got any insight in the accrual of that trial and maybe just a little bit of, you guys touched on the trial that I know you and Duke are considering, the remaster trial, sort of maybe how we're thinking about setting up an actual trial with that isn't really Bev versus LITT, but LITT actually is involved in.
Yeah, Mike, you can speak to this a little bit as well. The best trial was Bev versus steroids. And, I think this is one of the challenges with that study was just the clinical use of Bev, for radiation necrosis, which was a challenge with that. But you may have some additional information about that.
Yeah, I knew the PI of the study very well. There was a lot of enthusiasm about it up front, but ultimately a couple things happened. One is that many sites already had a bias and did not like the randomization between Bev and steroids. So, it was named the best study, maybe wasn't the best study. But then the other issue was that the company, after a couple of years, basically pulled the funding, right? So when they saw the accrual amount for that period of time, Wake was actually one of the top accruers for the study. But after a couple of years, once the company pulled the funding for the study, it just, we weren't able, it wasn't able to continue.
If I can just briefly touch on the remaster trial that we're going to be starting at Wake soon, and basically it's an attempt at further objectively looking at many of the issues we're raising. As Dr. Chan mentioned, radiographic progression is something we're seeing more as in our patients with brain metastases, they're living longer, and which is a great thing. but it's and we have new tools, particularly LITT, and so to address these new clinical dilemmas. And so this trial will look at patients with brain metastases who've demonstrated radiographic progression, who will then undergo biopsy, and we've highlighted the importance of that, distinguishing between radiation necrosis and progressive disease. Those patients identified to have progressive disease will then go on to undergo LITT and then be randomized to ongoing close observation versus adjuvant stereotactic radiosurgery. And we're going to compare those outcomes. And in those patients whose biopsy reveals a radiation effect or radiation necrosis, they will be then randomized to either ongoing steroid management, dexamethasone, or additional LITT, in comparing primarily time to cessation of steroids as the outcome in that arm. And for those that undergo the additional therapy, either SRS in the progressive disease group or LITT and ongoing needs for steroid in the radiation necrosis group, then further salvage therapies, including bevacizumab, will enter the protocol at that time at the clinician's discretion. So anyway, just a broad overview of some of our attempts to better understand optimal therapies and timing of available therapies for this patient population. So in the terms of recurrent metastatic disease, progressive disease versus radiation effect, radiation necrosis, so as we've talked about, early biopsy to establish the correct diagnosis and appropriate subsequent treatment is very important, as these are really indistinguishable on standard brain imaging alone. LITT provides a minimally invasive option for treating either, and so LITT is able to ablate the post-radiation inflammatory response quite effectively, as it is also able to ablate recurrent tumors effectively. And LITT has a number of qualities, but it overall is a less invasive approach in comparison to open craniotomy, and that can be relevant in brain metastases patients for many reasons we've discussed: their comorbid conditions, their potential need to be on DVT prophylaxis or anticoagulation therapy, their post-radiation tissues or other medical issues, making wound healing and infection a greater issue than for some other patient populations. So this was a multi-center study that we participated in, looking at sort of the feasibility and safety of laser ablation in patients with metastatic brain tumors. And the fundamental conclusion of the trial is that laser ablation is able to be provided safely and able to lead to desirable levels of quality of life and maintenance of KPS, as well as progression-free and overall survival in both patients with radiation necrosis and metastatic tumor. This slide again just highlights the similarities between radiation necrosis and metastatic tumor, and highlighting sort of a treatment course and some expected outcomes following therapy. There's been a number of studies looking at this population, and this table is just meant to summarize that the trials and the series that have been done to this point, comparing laser ablation to surgery in this patient population has revealed pretty comparable outcomes in terms of overall survival in patients with progressive disease undergoing LITT or surgery, patients responding with radiation necrosis who undergo LITT or surgery tend to have a similar response rate. For both treatment modalities, the likelihood that we'll be able to reduce steroid dosing or lead to steroid cessation entirely with either laser or open surgery is high and similar. And both in this, again, challenging population and very diverse population has an acceptable complication adverse event rate with either LITT or open surgery. This slide, again, just providing a little bit of a summary of a similar idea for those of you who are new coming into LITT. You may wonder, has anyone even looked at this? Who's using LITT? You know, and thousands and thousands of patients have undergone LITT now around the world, particularly in the United States. This has been a part of my practice for the last 10 years. And this slide just highlights some of the trials that have been done showing the safety, feasibility, and acceptable outcomes that are obtained for patients with brain metastases or radiation necrosis undergoing LITT. This recently published study highlights something we've touched on a couple of times today, and that is one of the issues for patients with radiographic progression, whether that's brain metastases, progressive disease, or in this case, radiation necrosis, is the need for them to have steroids and then subsequent potential complications or comorbidities associated with that, and how can we get them off steroids ultimately? Again, both progression-free, overall survival, and quality of life enhancement. And this study highlights that for patients undergoing LITT, the median was 37 days to steroid cessation compared to 245 days for those who did not undergo LITT and were managed medically alone. So patients undergoing LITT were 3 times more likely to be weaned off steroids before the study endpoint. Another issue that is relevant in this patient population is mixed pathology, again highlighting the value of biopsies. In general, we've found, looking at this, that up to 10% or more biopsies will show mixed tumor recurrence and radiation necrosis. In our center, and I'd say in general, mixed pathology is simply considered tumor progression and treated as such. Again, in the setting of identifying these patients, LITT provides the biopsy confirmation and then a useful therapy in one session. And so LITT can simultaneously treat both, and is quite valuable in that setting. as a minimally invasive treatment option, lesions in eloquent cortex may be treated with LITT perhaps more safely and perhaps more effectively than with some other treatment options. Of course, we have to always weigh the risks of toxicity of available options, and obviously craniotomy and open resection is always a part of the consideration. As is repeat stereotactic radiosurgery. But LITT, providing that minimally invasive cytoreductive option can be particularly useful in this situation, as it's focal and less invasive than open resection often. And so even in the most eloquent cortex, LITT may be an option. And in our weekly tumor board, these are the kind of cases we'll get into, and I think are particularly valuably discussed in a multidisciplinary way to find out, what are the options here? Could we do an open resection? Is LITT an option? Would we get the biopsy and cytoreduction through that? Is repeat radiosurgery an option? What about Avastin? What about further steroids? So discussing these things with all the relevant experts is very, very useful. And so LITT represents an excellent option for less than 3 centimeter lesions following stereotactic radiosurgery that show radiographic progression. In one surgical procedure, we get biopsy, pathological confirmation, and treatment, which is a valuable quality. It can be less burdensome and have less complications and side effects than craniotomy for certain patients. It's been shown now to generally decrease the time to steroid independence, and LITT and also, and again, we're looking at this in the remaster trial, post-LITT stereotactic radiosurgery may improve local control of recurrent mets, and it may be that we want to, in that patient population, combine those modalities up front, depending on circumstances. And again, as I've emphasized, multidisciplinary management leads to best outcomes. And I was going to move on to a few cases just to highlight some of the concepts we've talked about and sort of thought process in approaching this patient population. But I wonder if perhaps we should take a few questions now as well.
For a deep-seated brain metastases, when would you and what considerations would you have in LITT versus SRS?
Right. I'm going to be touching on that a little bit in our case reviews, but simply put, it allows us one additional cytoreductive option where we may be looking at a lesion that is just really, it's not feasible to do any kind of open surgical approach. And in those situations, certainly LITT is a consideration. And there may be times when even LITT we may decide isn't optimal for that situation, but perhaps repeat stereotactic radiosurgery would be. And I've got a couple of cases that highlight some of those considerations.
Great. And then this one might be relevant to touch on during your case review as well. But often get this question is sort of what expectations do you have around imaging post-LITT? What should you expect to see?
Right. Yeah. So what we've come to know, it's an important thing because just in general terms, for those who haven't seen much post-LITT imaging, is you can see a rim enhancement around your LITT ablation target, which if you're not familiar with it, can be a little off-putting, or you may wonder, what's going on? Are we still dealing with disease progression here, or what's going on? In general, though, we should still see reduction in the size configuration of the lesion and certainly the perilesional edema with time. Initially, we're going to see rim enhancement. Over time, what we start to see with that rim enhancement is quite a characteristic thin rim or eggshell enhancement, and that's quite common after LITT and isn't necessarily indicative of treatment failure. But again, obviously, other features of the imaging, the perilesional edema, patient's clinical condition would all also be factored into what we think might be going on.
Hi, I was wondering if the biopsy is done at the same time as LITT and there is a microhemorrhage. Does this change the efficacy of LITT in treating the lesion?
So biopsy can and generally is done at the same procedure as LITT. And certainly microhemorrhage does not negatively impact the efficacy or what we're able to accomplish with laser heating and laser ablation. Yeah, so that's a quick, simple answer to that question.
Thank you. Another question, a lesion that is cortex close to the skull, is that also, does this decrease the efficiency of LITT, giving the artifact that the skull might give during the treatment?
It's certainly something one has to be aware of. As with much of what we do in neurosurgery, we are working closely with our technical team, which includes technical experts from Monteris. And that's an important part of any LITT procedure. For lesions that are close to the skull that are very superficial, as you say, there can be more artifact in a case such as that than you would see in a more deep-seated lesion. And so important about that. So this is a software artifact that doesn't mean you're not heating that area. So there's two important issues about that. So with experience, and again, with excellent technical support, and one certainly is able to treat superficial lesions without question. And so, but one important, sort of word to the wise, again, artifact doesn't mean you aren't heating an area. So you want to be very, very careful not to make any assumptions of if you're having software imaging dropout, that those areas aren't being heated. So you shouldn't make that assumption. And sort of a related issue is it's still surgery, right? So we're creating real changes. We're ablating cells in the brain, and so you can have real complications and real neurological effects depending on what you're doing. So you definitely need to be careful and appreciate all those types of nuances. But again, in summary, it's an important issue when treating superficial lesions, but superficial lesions are definitely treatable with LITT. Great, these are great questions. I'm just going to quickly run through a couple of cases to just touch on some highlights. So this is a patient with lung cancer treated with stereotactic radiosurgery, 20 gray to this caudate lesion, and 2 years later we see local failure in that area, and you're seeing this rim enhancing mass increased in size. And so this it's a lesion that I would say is not the most amenable due to its location to surgery. Obviously, everything's accessible to the neurosurgeon, but I think it's an example of an area that I'd say we can get into quite safely and quite effectively with LITT and create a desirable laser ablation. And it's one after confirming local failure that we may also apply adjuvant stereotactic radiosurgery to the LITT cavity, as we did in this case. again, some of the considerations are that this is approaching a larger size, right? This isn't a small lesion, so larger size, showing failure in the past, maybe follow that up with LITT plus SRS. Here's a patient showing increased edema and enhancement beyond the SRS volume 1 year after 16 gray of SRS. Concerning again for radiographic progression and showing itself to be again, recurrence, and so again, because of the size, in addition to LITT, we applied a hypofractionated 4-course SRS to the LITT cavity, again, in an attempt to gain better control in a difficult situation. Again, some of the factors here: deep-seated lesion, although resection is possible, it is not without risks, and so something that, again, we might prefer to approach with LITT. Here is a couple of considerations, somewhat touching on the last question we had. So here is another lung cancer patient showing lung failure, local failure 9 months after SRS. So we've got 20 grade applied here, and we see where it was applied. Now we're seeing marginal failure there. And so this is one of those questions you bring to tumor board, one of those cases you bring to tumor board, and this is where multidisciplinary discussion is very valuable. It's right at the surface. Could we do resection? Definitely. I mean, we may want to do resection. I don't know if you can appreciate clearly here. Obviously, we're just showing a few images, but unfortunately, the lesion's in Broca's area, and it's already affected the patient's speech. So we might not want to rush in with further open resection in that very eloquent area. LITT is certainly an option, but again, as we've talked about, we may feel that any sort of ablative surgical approach in that exquisitely eloquent area might be best avoided. And so definitely an option. LITT could be done effectively there. But I just want to highlight that we're still, it's not a panacea. We can't just apply these modalities and these options without thought and without consideration. And so definitely an option. I wouldn't say somebody's wrong to apply it here, but if in discussion with the radiation oncologist, they feel they could repeat SRS in that area, sparing the patient from surgery, that might be the option. And in fact, that's what was done in this case. Here's a recurrent metastasis in midbrain. And so again, as all intracranial areas are accessible to open surgery, I still would propose that this is not an area safely accessed in an open surgery. And that LITT provides a very, very great option and tool in this situation to very, very accurately with our stereotactic techniques to get to this lesion and provide a cytoreductive option for this patient. And again, sort of in discussion, in contrast to the last case, stereotactic radiosurgery, we've highlighted the potential risks of open surgery, which we're all very aware of. But stereotactic radiosurgery can carry risks, and especially repeat stereotactic radiosurgery in a very sensitive area, in an area where even a small amount of perilesional edema may be very clinically significant and harmful for a patient. And so again, LITT steps in potentially in a case such as this and provides a good cytoreductive option with diminishing risk to the patient. And here's sort of another contrast, another brain stem. Now we have a recurrent metastasis in the pons, tumor along CSF surface. You know, we need to look at all the imaging, but I'll just propose to you that this was difficult to access in an open surgical way or with LITT. And so in this situation, one's preferred option may be repeat SRS. So anyway, that sort of highlights some considerations in this radiographic progression in brain metastasis patients with open surgery, LITT, repeat SRS, and steroids and Avastin for your consideration. And I would open it up for more questions, and thank you for your attention.
The team here mentioned a couple of times your evolving practice in recurrent brain metastases and LITT now often following with repeat SRS after the LITT. What considerations do you have for the team in terms of timing, dosage in using that repeat SRS after LITT, sort of timing post the LITT procedure?
So I can comment on that. You know, this is obviously something that we discuss in a multidisciplinary fashion. But some things we can use the literature to help us out, right? So in general, when you do SRS after LITT, we use a lot of the SRS to resection cavity literature where they actually show improved local control outcomes if performed within 6 weeks, right? So we usually try to get within 6 weeks, even if within 4 weeks if we can. And in general, patients tolerate that very well because they're in the hospital for so little time with LITT and sort of back doing their thing again. In terms of dosage, I think that one issue is volumetric, right? So if the patient had a small lesion to begin with, and then it became a larger lesion, much of the area that was previously irradiated is almost essentially kind of eaten away by the recurrent cancer, right? So almost kind of like a de novo application of SRS, right? Because a much larger volume than what had previously been treated. But if you're dealing with a lesion that previously was large and then now is still larger, even larger, that's when we tend to hypofractionate. So it's a matter of a cumulative volume that is treated. If both volumes cumulatively were large, we tend to hypofractionate the second time. And one other thing is we tend to use similar fractionation schemes as is seen in the radiosurgery to resection cavity literature. So you don't need to go to the, you know, most of the area has been treated with LITT, right? So there's probably just microscopic disease. So we tend to, you know, 16, 17 gray in a single fraction versus, you know, if you're doing a linear accelerator, 5 gray or 6 gray times 5 is a common fractionation scheme.
And Jim, just to sort of follow up on that, and in addition to those excellent considerations that Dr. Chan mentioned, we're again going to be embarking on the remaster trial, which will also provide some good objective understanding of this issue.
So I haven't seen any other ones come in, and I'll be respectful of people's time. We've gone just a little bit past the hour, but I would like to thank everybody for attending. Obviously, hopefully this was beneficial in sort of better understanding one institution's multidisciplinary approach. And I want to thank Dr. Laxton, Dr. Chan, and Dr. Strowd for taking the time this evening to share this. I think it was I found it a very interesting discussion. I'm hopeful that our panel found some benefit out of that as well.